Welcome to the What About Rural Health podcast, a place where research, policy, and real life stories come together to ask the critical question: what about the communities too often left behind? I am Chinasa, a development and global health policy strategist. And for me, this work is personal. From the village health workers struggling with limited supplies to the mothers walking miles for care, their stories shape the policies we need. Join me as we uncover challenges, spotlight innovations, and amplify the voices of those at the heart of rural health systems. Because every community matters, and it is time the world listens. Hello and welcome. You are listening to the podcast that asks the question too many people forget. What about rural health? I am your host, Chinasa Imo, and together we are uncovering the stories, challenges, and innovations shaping healthcare in overlooked communities. Today's episode is titled Resettled and Forgotten: Refugee Care, Identity, and System Gaps in Rural Communities. We are digging into a really important but often underexplored question. What actually happens after refugees are resettled, especially when they are placed in rural or marginal communities? What does it mean when refugee meets rural America, where the system meant to support them are already stretched thin and where access to healthcare and social services can be limited? In this conversation, we will talk about what it means to be placed in a community that may not have the infrastructure to meet your needs. What are those gaps? Who fills them or who doesn't? And how do care, identity, and belonging come together or fall apart at the intersection of place, federal policy, and local practice? Joining me in the studio today is Dr. Jessica Darrow. She's a brilliant scholar, educator, and someone whose work sits right at the heart of today's conversation. Jessica is an associate instructional professor and an affiliate of the Kippert Center for Global Health and Social Development at the University of Chicago Crown Family School of Social Work, Policy, and Practice, where she also directs the Kippert Scholars Program. Her research explores the systems that shape refugee resettlement in the United States, especially how policy, politics, and the construction of ideas of who a refugee is impact the kind of support people receive. She looks closely at how resettlement agencies are constrained by performance-based contracts and how that limits their ability to center rights-based care. Her work also examines how resettlement sectors respond to the Trump administration's rollback of refugee protection. That's a tough one, and I hope that you would chime in your conversation on this one. What resistance look like on the ground and how the system is now being reformed by local communities and state actors. Jessica also conducts a holistic analysis of the care system for unaccompanied minors in the US and at the Mexican border, looking at it through the eyes of community stakeholders, diaspora networks, evacuees support systems, and legal aid providers. But beyond all of that, Jessica is someone that I admire a lot, not just for the depth of her scholarship, but for her courage. She is one of those professors that I have seen consistently use her voice to speak up, especially for those who often don't have access to the rooms where decisions are made. I've had the joy of co-instructing with her, and I have seen firsthand how powerful she brings together activism, scholarship, and her heart. And today, I'm really excited to have her join us and for you to hear her out. So, Jessica, welcome to the studio of What About Rural Health?
Chinasa, thank you so much for that beautiful welcome. I feel humbled by the the way you talk about the work. And one of the things I've been thinking as you're talking and trying to tune out anything you're saying about me is that question formation is so important. The way you frame things is so powerful. I was getting lost in your words in some ways, thinking about care, identity, belonging, and the way you speak is so comprehensive, even packed into one sentence. I was writing down all these notes of things I better remember to say. So I think it's going to be a rich conversation and mostly because of your incredible framing. So I'm grateful to be here and looking forward to the conversation.
Thank you so much. So before we dive into the specifics of rural resettlements of refugees, I would love for us to also zoom out a little bit, and look at the bigger picture. We are living through a time where the global refugee crisis is growing across multiple regions, from conflict zone to climate displacement to political instability. And we are seeing more and more people being forced out of their homes to move across borders, often involuntary and without safety nets. From your perspective, what are some of the key ways these global displacement patterns are shaping or straining social services, particularly when these refugees are navigating unfamiliar systems?
Oh, great. Okay. Thank you so much, Janasa. You put your finger on it. I think the global context is shifting always. Mm-hmm. I teach a class on refugee policy, and every single year that I teach it, I have to change the basic context, background, and framework of the course because every year UNHCR is documenting, tens of millions more forced migrants that have to sort of update the numbers every year. And it's shocking. In the 15 years I've taught the very same class, more than 10 million more forced migrants every year. So it's exponentially getting bigger over those years. And I think one thing I would add to your framing before we dive in to answer your question is that on top of this notion of forced migration, we're seeing, unfortunately, a rise in sort of a secondary driver of migration, which is the effects of climate change.
Yes.
And we don't think of that necessarily as the same as forced migration. There's no risk of persecution. There's no fear or experience of government persecution. Mm-hmm. So those folks moving aren't considered refugees, and yet they can't necessarily stay where they are. Their homes may have been ruined. So seeing the intersection of climate disaster, climate change, the effects, say, of the desertification of huge swaths of the Sahel, right? Like you see the desert growing, deeper and deeper, periods of drought. People can't farm, people can't raise cattle, so they have to leave. And then there's an intersection of these effects of climate change and the kinds of violence that leads to forced migration. So we're seeing a dramatic change in the drivers of migration over time. And all of those drivers of migration are related to, unfortunately, a lower and lower resource pool to receive refugees. We're seeing more and more xenophobia, more and more closing borders, more and more militarization of borders around the globe. So, the very sad paradox here is that as we're seeing a rise of global movement, we're also seeing a rise of nationalism and the closing of borders, leading to more and more dangerous contexts at borders. And I think for us to think about the borderland regions as particularly important political spaces to look at, it's where we see the evidence of xenophobia and the evidence of need come into conflict.
Thank you so much, Jessica, for that response as you were talking. And I'm always coming from my own perspective to say, like when guests explain things to me and it links and it connects to like a situation, and I'll be like, I am Nigerian. And when you were discussing about it, it reminded me of a community in northern part of Nigeria, where all of these things are happening together. There's droughts, there's climate change issues, but also there is intra-border conflict between communities that is creating a whole lot of issues. So, like, people are displaced, but they don't even know where to go to because the next place could have been affected by heavy rainfall, and there is so much flood that they can't even move there, and that's becoming so much problem to grapple all at once when all these things are combined together. But before we continue on this, I will take a quick break and then we'll come back and continue this question because I have a follow-up for you. If you are enjoying this conversation, don't forget to subscribe to What About Rural Health on all podcast streaming platforms. We are on Spotify, Amazon Music, Apple Podcasts, Listen Now, and so on. And yes, we are also on YouTube. Your support means a lot to us, so please like, leave a comment, share, and most importantly, drop us a review. It helps others discover this important conversation. All right, we are back to the episode, and you are still listening to What About Rural Health with Chinasa Imo. And with me here in the studio is Dr. Jessica Darrow. So, Dr. Jessica, when you were explaining this to me, and I'm like, this is more than a humanitarian crisis. It's also a health story. And I'm a health person, so I have to bring it home. Because people are moving, they are being forced to leave their places, and it's invariably reshaping the landscape of healthcare access, not just for those individuals and their families, but also to the health systems in the countries where they are resettling, especially if those places are grappling with their own under-resourced issues. So from your work, how do you see this global displacement crisis changing what healthcare systems are being asked to do, both here in the US, but also beyond?
I love that question, and I would love to pivot it and ask first, what do we see outside the US, and then what do we see within? And the reason I'm thinking about that is that lower resourced communities in the U.S. struggle, right? Struggle is not relative. And also, the scale of need in lower resource communities in the U.S. isn't the same as the scale of need in the surrounding countries from where refugees tend to leave, depart, and then arrive for first asylum. So, for instance, you see refugees in the MENA region find themselves in Lebanon, in Jordan, countries that are not nearly as resourced as the U.S. And you've got 1/5 of the population are refugees. So the scale of need there is so tremendous that the kind of issues we might face with rurality in the U.S. are a bit different, but I think there are things we can learn from abroad. And I wanted to bring to you insights that I took from a scholar. As I was getting ready for today, I was remembering this keynote conversation that I went to at a Canadian forced migration conference in 2019. And the scholar she's from Nairobi, Kenya. Her name is Carolyn Kihato. And I think at the time she was at a university in South Africa. But she was talking about the implications for humanitarians when there's pushback from resource poor communities. Newcomers are arriving, and specifically around addressing health. And at the time I was thinking, we have so much to learn in the States. We have so much to learn. So that's why I want to start not thinking inside the U.S. borders. One of the things that Dr. Kihato was saying is that if we think about access to healthcare through a rights lens versus a resource and access lens, then we approach the question a little bit differently. And she was really thinking about communities that push back on newly arrived folks entering their community. That pushback tends to come from a fear of your own resources being taken away.
Yes.
So her suggestion was, what we need to do is think less about who's a refugee and who's not, who's quote unquote native to this space and who's a newcomer, and instead think about issue-based solidarity. What we all have is a need for good health. We all have a need for potable water. Yes. We all have a need for healthy food. We all have a need for a roof over the children's, sleeping place. So if we think about that in resource-poor communities, then anything we're doing for the refugee newcomer, we're doing for everybody in the community. And when we bring this rights-based lens to answer your question, then I think we sort of approach it from a space of solidarity. And we look for solutions in abundance rather than in deprivation, which tends to separate people and work from a space of fear. And I'll pause for a moment to see your thoughts on this, because I'd love to be in conversation around it. But before I do that, I'll pin to when we do talk about coming back to the States, I think there's not just a lot to learn from those lessons that Dr. Kihato brought to this conference, but also some assumptions I've always had about rural US, and what it might be like to be a newcomer in some of these spaces, that were blown away in my research. My assumptions proved to be wrong in some cases, and that is so heartening. So we can kind of come to that in a moment. But first, I'd like to hear what you think about that frame on health. Health is a human right, even though in the United States we know that it really isn't activated as a human right.
You bring the question back to me because, funny enough, I come from, a place where we categorize health within the global health space. That is most countries minus the US. And within that framing, health is a human right. Even though we grapple with, resource issues, grapple with government determinants of health and every other kinds of determinant, but it always something that we approach from the fact that at least every human being have the right to access health care. What that access look like is what is still unknown, but at least we agree on that. And then me coming to the US, and when I say health is a human right, and people, students, my fellow students in class, people I'm having conversation with, will look at me like, where is this person coming from? Who told you that health is a human right? Health is as much as how much you can afford, how better insurance you can buy, and how much economic power that you possess to purchase the kind of quality of care that you need in and within the US context. That is the kind of way, and I guess that is a socialization that most US citizens have had from get-go, that they don't see health as a human right, and because of that cannot demand in ways that they get the kind of services that they would want, especially in limited resource environment, because then you'd be like, well, if I go, say, for instance, I don't have status, I cannot go to access care, because then that becomes a problem, because we don't see it as a right, rather a privilege that you need to acquire only if you have a status. But this question that you asked me brings me to the next thing that I wanted us to talk about. And, that is something that sits beneath the surface of policy decision, because all of these things are tied to the policy ecosystem, right? And that is about how we construct identity itself, within the policy space. How do identity politics and dominant narratives around refugees shape the kind of support that you see them receive? And how does this system respond, towards their health needs, their social needs, especially in low resource environments?
I love this question, and this is where I think I've been a little bit surprised. Now, admittedly, the majority of my research in refugee work has been done in an urban center. Mm-hmm. I've done some work in some eastern seaboard, more rural communities, and some southern, more rural communities in the U.S. Related to my unaccompanied minors research, and a little bit in relation to refugee resettlement. But I certainly have also done a lot of literature review of other really excellent studies. And I'm happy to share resources with you where I get some of my information here. I'm currently involved in a study that's just getting underway, where we're doing a 6-state comparison of how these different states are responding, the communities in these states are responding to the Trump administration's policies ending refugee resettlement, and really more importantly, how communities are coming together or not. I love the way you phrased that in the beginning, or not, to support the health of refugees and other newcomers. But in direct answer to your question, I think there is an underbelly of sickness in the United States rooted in white supremacy, in which people who have access to resources, when they share them, they see themselves as sharing resources, and they like to see themselves as helpers. They like to see themselves as savers. I think this is connected to the Protestant ethic that the United States dug deeply into after the initial establishment of the country on stolen land. But I think there is something here. There's something around the notion that there's a superiority in being able to help somebody. right? There's a humanitarian need, and if I get to meet it, I feel really good about that. But it keeps the person in need in some sort of inferior state. And this is something that I've seen in some of the rural communities that I'm talking about. A welcoming, pride in a church coming together and doing really beautiful work to help a small enclave of refugees, typically from a very similar place, right? So you see these, and bear with me here, you see like ethnic enclaves around work. So a meatpacking plant, say, in Indiana. Well, the people who tend to work in meatpacking plants in Indiana are refugee populations. You don't need to speak English to work in these places. You need to be strong. You need to be able to sustain in cold environments for a long period of time.
Wow.
It's very tough work. Not everybody wants to do it. And it's stable work. So for a newcomer who doesn't speak English and who's able-bodied, it's not a terrible job. It tends to pay well. So you get these enclaves of people from similar places around the world, say from Somalia, all working in one meatpacking plant. Yeah. And the surrounding community knows that that's who's working in that plant. And there's some receptivity to that. There is, not in all cases, but this is something I have been surprised by. Politicians in traditionally conservative red states supporting refugee resettlement. And I had to ask why. It wasn't what I expected. And what I found is that industry in those states, and specifically in some rural communities that do things like meatpacking, that do things like vegetable picking, farming, rely on the labor force of the refugee population. So you see the political will to resettle a population in a smaller community like this, and therefore make sure that they have their needs met. Housing, healthcare. Now, are they fully integrated into community? That's a question, I think, for someone who's working with refugees themselves to find out how it feels. What form of belonging do I have? The word belonging, to your point, and the concept of identity are so complicated. To some extent, they are integrated community members. Because in the U.S., the only way we define that is, are you working and able to support yourself? But are they fully integrated? I think you would have to ask them. And that's the research I love, is research done by refugees with refugees who ask this question. What does it feel like to be here? I'll quickly return to this notion. Some of these communities that I had expected, because of my own biases, to seem xenophobic, in fact, appeared quite welcoming. And underneath that welcome, there's this savior complex. There's this notion that we are here saving people from some horrible homeland that, that they're lucky not to be in, when in fact, when you speak to people who are refugees, they would love to go back home. Few people ever want to leave the homeland where their ancestors were and where their loved ones are buried. So there's this like mixed match, I think, between what belonging looks like from the perception of the receiver and the reception of the newly arrived.
Wow, this is fascinating in the way that you were describing the reception that refugees receive in even places that we think would not be able to receive them. And it brought me back to the question of the identity that we're talking about, the curation of identity within needs. Let's remove the veil, and look at it from the actual issue, the actual point. The curation of this identity is around the needs of those local community. There's a thriving meatpacking business, and we don't have enough hands. So we create an identity around that to bring in these people and then support them in ways that they can support each other, whatever that community is. Because if we bring 50 Kenyans who speak Swahili to, say, Minnesota, where they probably don't speak good English, and you put them there, yes, you've given them a community to support each other, that's fine. But there is, at the upper layer, of experiences, and what that means is just the other identity formation of, we need workers, and these people are easy hands to do our work for us. Let's shift a little bit away from this conversation, or just maybe foray them better. Because when you were talking and describing all of these things, I'm seeing alignment, I'm seeing fragmentation between what happens in the local and what the federal makes us want to see. So between policy and practice, it feels like the context within communities is different, and the context outside of policy space is different. And I'm curious, why are those things that way? And is there something that is different when you look at it from globally, how other places are modeling how they treat, refugees, like other countries outside of the US, how they are modeling how they treat refugees or how they structure refugees integration?
Can probably answer the first question for hours and days, because thinking about the implementation of federal policy and why it looks different in local communities than it might be thought to look, at the federal landscape. That's my bread and butter. But I maybe would approach that with an example to try to make it as specific and narrow as possible and see what that reflects of the larger question. When we think about U.S. refugee policy before Trump, and we spoke about this just a little while ago, refugees are considered to be integrated from the policy perspective as long as they're financially self-sufficient. If you're economically self-sufficient, and all that means is that you're not taking public aid, financial public aid. So if that's the case, then you're considered self-sufficient. The government's done its job. But when you're in a community and you are, say, working in a refugee resettlement agency, and you have a family where maybe there's one person in the family who can go to work, get a job that can support the family, they might be considered self-sufficient. But what happens when there are mental health needs in that family? What happens when there are serious examples? I can think of serious issues of back pain, bodily pain that are real and that no one can find the source of. So you've got somebody coming back to the agency again and again and again complaining of pain, and doctors that are based in U.S. systems of Western systems of medical care not able to source the pain because they don't understand how this person is oriented, what's happening in their body and how it connects to their mind and how it connects to their pain. They're not asking the right questions. Then we have an example of a family that's considered self-sufficient but is deeply hurting and their needs aren't getting met. And I think the caseworkers that I've been lucky enough to follow in my work are, so many of them experience very serious moral distress because they can't resolve those issues because their jobs aren't designed to solve those issues. And the systems that we have in the U.S., which are typically funded by federal, state, or local government, aren't designed to address those issues. Really, everything in the U.S. is designed around getting people to work. Patch them up quickly enough to get back to work, but address the underlying issues. That's not even how our healthcare system is designed. We don't really invest in preventative healthcare in the way that we could in this country. So I see sort of little examples of every part of your question in any anecdote I think of from my own research, where the federal policy asks really for one thing, and the person who's delivering that policy is left facing the fact that they're not meeting the deep needs of families, especially when it comes to physical and mental health care. And we haven't even touched on trauma. If I address your second question quickly, I literally was just recently this past summer in Kenya, working with some global colleagues at the university, the Jomo Kenyatta University of Agriculture and Technology. I'll call it JKUAT. And I was learning through them and their partners with the National Public Health Institute that the approach to resettling refugees in Kenya is changing. For generations, Dadaab and Kakuma camps have been there. Refugees have been having generations of children because the camps have been there for so long. So people being born and what state do they belong in or belong to? And local integration has just not been the focus. But for the first time, Kenya is committing to a new approach to try to think about the surrounding communities of the camps, really being ready to interact with, absorb, and connect with folks from the camp so that there is some local integration. But they're looking elsewhere to ask, how is that done well?
Wow.
I think it's really interesting that in this place where refugee camps have been there for so long, there's a lot to learn from around the world, and they're asking really good questions. But one of the things I said to them is, I really advise you not to look at the United States for your answers. It's sort of funny, but terrible. I think there are pieces to learn from lots of different models. In Germany, you really aren't allowed to work until you've mastered the language.
Yes.
So something I struggle with there is it's really good to see the kinds of investments in language acquisition and other kinds of belonging that would allow you to access healthcare and other sorts of resources more readily. But the right to work is something most people want. Not the responsibility to work like we have here. You have to work or you're in trouble, but the right to work. So I think to answer your question, there are bits and pieces of models around the world that could be really effective. And then the local context really has to grapple with what works in this place. And then I think the final sort of punchline there is I wish that all of these policy solutions were thought through from the perspective of human rights, as we started with. And I don't often see that being the policy-based solution approach.
Thank you so much for being here. And to our listeners, please subscribe, comment, like, and leave your review if this conversation had a different meaning or made you think differently from ideas that you already have about refugee and resettlement around the world. Please leave us a comment. And as always, let's keep asking the question, what about rural health? Until next time, I am still your host, Chinasa Imo. Bye.